recent doctoral graduate, Hanish Kodali, who is presenting work that he has presented at the Society for Epidemiological Research, and will be presenting at another conference, I believe, coming up if that hasn't happened already. Maybe you can tell us where you're presenting this work. But we're very proud of Hanish and all the work he did during his dissertation. And he's going to present today part of that work titled The Joint Association Between Race, Ethnicity, and Education on All-Cause Mortality Risk Among U.S. Adults aged 25 and older, a mediation analysis with telomere length. So thank you for agreeing to present today, Hanish, and I will hand the mic over to you.
Wow. Namaste, everyone. I'm Hanish Kodali, a PhD candidate in this department. Before I start, I would like to express my gratitude to Dr. Waldron, Josephine, and the EpiBios Forum for holding this event and giving me an opportunity to share my research with you all. Today, I will be presenting our research titled The Joint Association of Race, Ethnicity, and Education with All-Cause Mortality Risk Among U.S. Adults aged 25 years and older, mediation analysis of telomere length. It is a bit of a mouthful, so let's break it down. Okay. So I will be presenting our work in following sequence. So starting with background, racial and ethnic minorities, especially non-Hispanic Black, experience high mortality across all education level compared to non-Hispanic whites. Significant inequities in mortality rate exist across different socioeconomic status, particularly in education, and these persist in US. While education is known to reduce mortality rate, even highly educated Black adults have higher mortality rate than less educated adults from other race or ethnic groups. Telomere length, a biomarker that shortens with age and chronic stress, may mediate this link between SES and mortality. Racial and ethnic background and educational attainment are associated with variation in telomere length. There are studies which have shown that Black individuals tend to have a longer telomere length than white individuals at birth, while higher education is linked to longer telomere length. So given this background, our study investigated two primary aims. First was to examine the joint association between race, ethnicity, and education on all-cause mortality. Second one was to explore the mediating role of telomere in this relationship. We conducted a retrospective cohort study using publicly available data from Enhanced 1999 to 2002 and 2019 linked mortality file. Our main outcome was all-cause mortality, and the time to death was calculated from interview to the death or until December 31st, 2019. Our primary exposure was joint association of race and ethnicity. We considered white, Black, and Mexican American, and educational attainment was categorized or considered were less than high school, and some college or more. Telomere length served as a mediator in this analysis. For analysis, we first performed descriptive analysis to characterize the study participants stratified by mortality status. And then to address the aim number one, we employed Cox proportional hazard regression. And to address aim number two, we used causal mediation analysis to estimate the total direct and indirect effect of telomere on this relationship. All these models were adjusted for age and sex. So in the descriptive, you can see that the groups were different among those who were alive and those who died. In this graph, representing the results from aim number one, you can see a strong educational attainment and a strong inverse relationship between educational attainment and mortality risk for both white and Black. You can also see or appreciate that as education attainment goes down, the risk of mortality increases in both the groups. Additionally, maybe you can appreciate this in among the Black who had college education and some college or more education. Compared to them, those individuals have still higher mortality risk against their counterpart among the white population with similar level of educational attainment. Within the Mexican American, there was no statistically significant difference in all-cause mortality risk across different levels of education attainment. Moving to aim number 2, the analysis shows that the indirect effect of telomere length on the relationship was either null or closer to null. You can see this on this graph. For limitation, these were baseline measurements. We had the baseline measurements for race, ethnicity, education, telomere length, age, and sex, which do not guarantee a clear temporal trend. As an observational study, full control of all the confounders was not possible. Exclusion of the participants with missingness in the race and ethnicity, telomere length, or other covariate data may introduce bias. We saw when we compared the two groups, we saw that there was a higher proportion of females and blacks among those with missing data. This might have underestimated the association among the Black population. The study focused on telomere length as a mediator of it's actually telomere length is considered as a proxy for cumulative stress, which may be due to the socioeconomic inequality, but there may be other mediators which may play a role in this association. For the strength, we utilized a large nationally representative US sample with approximately 2 decades of follow-up data. We employed a causal mediation analysis within counterfactual framework to assess the role of telomere length. So to conclude this presentation, as we saw in the graphs, white and Black populations show inverse dose response association between education and mortality, which is consistent with the social gradient theory. Social gradient theory states that the people with low socioeconomic status have worse health outcome than those with higher economic status. And we also saw that Black experience higher mortality rate than whites at all education level, supporting the diminishing return hypothesis, which suggests that racial and ethnic minorities receive fewer health benefits from socioeconomic status than majority groups. It can be, the possible reasons they suggested were like structural or institutional discrimination limits the benefit for Blacks. Lastly, we also saw that high mortality rate was observed among the Blacks with some college or higher education compared to whites with similar education level. We also saw that among the Mexican American, we did not find any significant association, and it aligns with Hispanic paradox, which states that despite lower socioeconomic status, they show comparable or better health outcome than whites. And it may be due to cultural, social, or biological resilient factors. Now we also, and for the aim 2, we saw that the telomere length did not significantly mediate the association, contrary to the weathering theory. Weathering theory suggested that chronic exposure to social or economic disadvantage can lead to physical health decline. And the possible explanation for we not finding this association or this significant association may be that we need a longitudinal telomere length measurement. Because one study showed that even though that cohort showed that even though at birth the telomere length was longer for Black against white population, but during the course of life, they also had rapid telomere length degradation as compared to white population. So before I end, I would like to extend my sincere gratitude to my dissertation chair, Dr. Borrell, for her patience, guidance, support, and mentorship throughout this project. I also deeply am thankful to my dissertation committee members, Dr. Jones, Dr. Waika, and Dr. Valerie, for their invaluable feedback and encouragement. Additionally, I would like to acknowledge the faculty and the staff at CUNY School of Public Health for their continuous support throughout my journey at SPH. Before I take questions, on this 23rd anniversary of September 11 attack, I think we can take a moment to remember those who lost their lives and honor the resilience and strength of the city. Thank you all for your attention. I welcome any questions you have.
Thank you, Hanish. We can take a couple of questions now. If you have a question, just go ahead and unmute yourself and.
Hi, Anish, can you show me? I want to see the number again. Can you show me the slide that has a telomere length of the one more forward?
This one, right?
Yeah. So this is the telomere length center. That's like 0.1 kb is the overall.
Yeah.
Oh.
Yeah.
And it just number seems pretty weird because like human telomere doesn't go that short. So human telomere is usually 5 to 15 kb, and then once it got like below its critical length, which is I believe it's more than a kb for sure, then it's going into the senescence, and then like it's dead. So the 0.1 kb sounds inaccurate to me. So
yeah. So
yeah, and other thing is
it's also less than any of the other entries.
Yeah, just 0.1 kb telomere length, like survive live human cell. I don't think that exists. That can exist because I study telomere, and then that's not the range that human telomere can be. And then other thing is like telomere is like the short gets shortened after the cell cycle, and then age is like critical like factor for affecting the telomere length. And so I think age should be definitely considered if you do anything related to telomere. But just main thing is just number really doesn't make sense. And then what does that mean that is minus 0.2 kb is that's already you are using the genomic so those like number seems probably need to double check. Number doesn't make sense.
Yeah. No, I completely agree with you. This is not the actual, I mean, I should not have had the word kb over there. The telomere length in the study population was between, I don't remember exact range, but it was in the normal range. The value I have used here is centered to mean of the whole population I have. So that's why you have 0.1 here. It's not, this is not in kbs. This is just centered to mean. You know what I mean?
Oh, so K, okay.
So, the kb, I forgot to remove that, but yeah, it is not in kbs. This is centered to mean. Like you said, in original population of enhanced, the numbers are between, it's not exactly between 5 to 15, but yeah, it is in the normal range. It is not in decimals. It doesn't start in decimal. It starts somewhere like 5 or something.
That makes more sense. When I saw the unit, I just read it as
My bad. I'm sorry about that. And also that's why you see that the negative, it just says that, those are, right. Now it makes sense, right?
That makes sense.
And for your second question, sorry, Professor Wondren, you had a question?
Well, only just to follow up on that and say it would make more I would understand it better if you just presented it in KB. Because also I would think that overall, if it's mean-centered, it should be 0.
Yeah. So yeah, I could have presented in KBs. That's where I started. That's why I put the title name, but I forgot to remove that. I did not put the KB here because for my analysis, I used the centered mean, centered values. Second thing is it should be 0, as you said, but I started the taking mean with the whole population. But as I applied the exclusion inclusion criteria, this was the centered overall mean for the remaining sample in my for the analysis.
Mean for the whole population with different age groups is?
Yeah. So regarding the age group, regarding the question related to age group, all the models were adjusted for age and gender. Does that answer your question?
Yeah.
Right. Any other questions? Otherwise, we can let Professor Schooling give her presentation and then take questions after that, as well as any follow-up questions for Dr. Kodali and in relation to the second presentation as well. So thank you very much, Anish.
Thank you.
I hope you will stick around for the discussion afterwards.
Sounds good.
Great. Yeah, okay. All right. So our next presentation is by one of our own faculty, Professor Mary Schooling, who our doctoral students will know from instruction of, what is it, Epi4?
Yeah.
And Mary is an expert in causal inference and in in general epidemiological methods, including methods of Mendelian randomization. At least that's what I know, Mary, before I can let her correct me or update that. So Mary's going to give a talk today on chronic disease epidemiology and public health successes, failures, and new approaches. Here from my office. Thank you for coming up.
Right. How do I make it go on to the next page?
Sure. You can
Okay.
use the space bar or the.
Oh, okay, so not okay. Well, thank you very much for inviting me. And I hope what I'm going to say isn't going to depress you all too much, but that's just the way it is. Oh, that doesn't make it go on.
Yeah, let's see. I'll try now.
Yeah, there it is. So start off, I just wanted to mention why we care about chronic diseases, because I've been looking at the new CEF consultation on the MPH, and it says we're going to provide the scientific underpinnings of chronic and infectious diseases, e.g. the etiology of disease, environmental effects, interactions, beyond what would be in a general biology, physiology, or anatomy course. So looks like it's going to be more central to the new MPH than it was, but that could all change. But that's one reason for taking an interest. And the other reason is that if we look, we can see that non-communicable diseases are the main causes of years of life lost. They were in 2016, they're projected to be in 2040. I mean, I admit this doesn't take account of the pandemic, but the pandemic was a one-off item unless we expect it to come back again. So I think that, we're still seeing key chronic diseases as the major issue, or a very major issue in public health. Ischemic heart disease, stroke, kidney disease, diabetes, they're all there at the top, and then cancer is a bit further down, and some cancers we know what to do, like lung cancer. Don't smoke. And there's really interesting features of ischemic heart disease that might help us understand it if we knew more about, if we could explain them. For example, you can see here that mortality from ischemic heart disease is much higher in men than women. Can we address that? What's causing it? And we can also see on the plot on the right, which is showing you men and women in different age groups from I think 1900 to 1991, and it's showing you that for people aged about 35 to 44, suddenly the plots of deaths from CVD come apart, and there's higher rates in men from about 1910 onwards. So something must have caused that. It didn't happen by accident. And people have, one obvious explanation is smoking, but the smoking is too late to make this difference. And you get exactly the same pattern in the UK. So something made it happen, this difference. So we could obviously then make it unhappen, but we don't know why. And Michael Marmot in 1975 said, conventional risk factors only partly explain the observed gradient in coronary heart disease. And in 2015, Zati said virtually the same thing, that we can't explain the decline, nor the similarities, nor the differences between men and women. So we seem to be, we've got some weird things and not many explanations. And just to put it in the context of cancer, just the trends over time in the US, CVD has been going down. So there has been some great success there, because that's the red line on the left-hand side. And you can see CVD going down substantially, and that's age standardized. And then cancer is sort of flat and very slightly going down. So very different trends for two important public health issues. And then diabetes prevalence, as you would expect on the right, has just gone up and up and up. So what are the public health interventions that are going to do something about, explain these trends or counteract them? And the key recommendations from the WHO are about tobacco use, physical inactivity, alcohol, diet, air pollution, and poverty. And if we go back to people's thoughts about ill health almost 200 years ago, they're pretty much the same things. So alcohol, hunger, anxiety, poor housing and clothing. So that seems to cover some of the socioeconomics. So it's not really as if we've sort of moved on very specifically in those 200 years. So bearing in mind these CEF recommendations, I made up a new approach. So I think that we actually have to understand the biology of these diseases. And there is quite a lot of it about, in that when you look across medications and dietary items and even some habits, there's commonalities in that there's a whole load of things. These things here, aspirin, metformin, statins, some other drugs, some Chinese drugs like cordycepin and berberine from traditional Chinese medicine, diet, physical activity. A lot of them all work by the same pathway, or at least we think we do. They do this one called AMPK, which is an evolutionary conserved central monitor and driver of cell metabolism. And that's been this stuff has been written up for the last 40, 50 years. The first idea was first put out there in 1973. And so these drugs or interventions that might work by AMPK in several different ways. That's why it's got alpha, beta, gamma. They affect glucose and insulin. So that's metformin, which we know affects glucose and insulin. Statins, which we know affect lipids, as does mpordic acid, SLG2 inhibitors, I think. And then berberine, I think, is more on the glucose and insulin. And then, healthy diet is supposed to affect all of these. But exactly, if we saw the diet as either raising or decreasing AMPK as the way it worked, then we'd be able to classify everything and say, this is good and that is bad. And just of saying very vaguely, what's a healthy diet? And one or two other things I've put on there is I've put inflammation and infection with no arrows, because I don't think they do actually cause anything. They're a symptom, just like if you cut your finger and it gets inflamed, it's a symptom, it's not a cause. The inflammation didn't cause the cut in your finger. And there's got to be something, I think, about androgens, because of the fact that men are more vulnerable, and the same pattern is seen in trans men. So it would seem to be that it's to do with the actual hormones. So how do we test a model like this, or any model? And there are a few problems in that one, because these eminent people have made some rather damning remarks about observational studies. That Greenland was saying 20 years ago that the results of stratifying, i.e. selection bias, can be as bad as the effects of confounding. And then 2007, these people opined that confounding could probably generate everything we see. And then a more sort of rigorous look at it, they compared evidence from observational studies with randomized evidence, and found most of the time it wasn't there. So we need to do something about this, or we're just going to go round in circles forever. So just how do we even spot the biases? Confounding generates type 1 error. So you will eventually find out if you're wrong, because the trial will say there was no effect when there was. But selection bias on survival generates type 2 error. So you never find the true hypothesis, because you might see a null association. So then you don't investigate that. And I think that's particularly important for things in old age, where blood pressure in old age was thought to have no effect on mortality because there was no relation. Then they did 3 trials and found that blood pressure drugs were really good for old people. And the problem was the selection bias meant they couldn't see the true relation in old people. And the same when you've got a competing risk of the outcome. So lipids work brilliantly for heart disease, but observationally, they don't seem to work for stroke. That's because the person has to survive their heart disease to have a stroke. And if they haven't, you can't see, they're not in your study and you can't see it. And of course, the worst disease where that happens all the time is Alzheimer's disease, because you have to survive to be old to get Alzheimer's disease. So something like smoking appears to protect. Of course, smoking doesn't protect. It's just that the smokers who survive to be very old are very different from the rest, and they survive to get Alzheimer's disease. So there's a lot of selection bias in these studies of old people. And a symptom of selection bias is associations changing by age. Because in the young people, you have no bias, in the old people, you have a lot of bias. And if the associations are different in those 2 age groups for no known reason, the most likely one is bias. So you can spot it there. And so how do we solve this? So you could use a target trial. So the target trial says you mustn't have an arrow from exposure to anything, including survival to recruitment. So if you get rid of that arrow, your DAG should be roughly okay. Well, you'll still have confounding, but you won't have selection bias. Still got lots of confounding, but you're not selecting on exposure. So, as Greenland said, you should be roughly okay. So target trials sort of acknowledge the problem, because that's why they make such a fuss about the exposure, and the studies start being the same. Instrumental variables, the interesting thing about them is they now have a whole chapter in modern epidemiology rather than a whole page. And here we're using an instrument as a proxy of the exposure, which is independent of the outcome given the exposure and the confounders. So again, what we do here is there's my instrument. And with any luck, if that instrument is independent of all those other things in the middle, I should be able to get a reasonable estimate. So I don't, as long as my confounders don't affect the instrument, and as long as the instrument doesn't affect the outcome. So that's all lovely. We just need the instruments. So where do we get them? So one example is laws provide great instruments. So here is an example of one we did in Hong Kong, where we looked at the effect of whether the minimum wage would reduce suicide, on the idea that if you're richer, you're less likely to be desperate and commit suicide. And the thing was that the minimum wage was introduced at one time, so you could just compare the suicide rates, essentially, before and after. And you don't, and the way we thought of it is that's still an instrumental variable analysis, where time is the instrument, because of the time you make the change, which affects the minimum wage. And then does that affect suicide? And so the insight that gave us, so we don't care about those other stuff because they're not going to make a difference, you know. There's no confounders of minimum wage on suicide. But we do have to think that there may be some changes over time that might affect the suicide rates, particularly if we compare them over a long time period. So there could be a link there. So, and in fact, everybody who knows who does these studies knows that, but they don't know how to explain it. So they say they're adjusting for some confounders when they're actually adjusting for secular trends. So you adjust for secular trends here. And then we did all that. And we can see that the blue line is the suicides before the law was introduced. The red is what would have happened if the minimum wage hadn't been introduced. And the blue line after 2011 is the suicide rate after the minimum wage had been introduced. So it looked to us as if the minimum wage had a big effect on the suicide rate. So that was great. Nice way to be able to evaluate a policy. And so I'm forever looking out for opportunities to do studies like this, because you can make a valid causal inference as long as you can find the instrument lying about. The next place where you get genetic instruments is now in a very, very unpopular area called Mendelian randomization, where nobody wants to publish any Mendelian randomization studies anymore on, I'm not quite sure what grounds. But the thing about Mendelian randomization is you're using genetics as an instrument. So you've got the same assumptions. You've got to make sure your genetics don't somehow induce selection bias, and you've got to make sure that they don't affect the outcome directly. But once you do that, you get what in previous studies have been shown to accord quite well with the results from RCTs. So the example I'm showing you here is genetic instruments for polyunsaturated fats on ischemic heart disease, because that's the first heart disease. I wouldn't do stroke because it might be all nonsense. And lifespan, because lifespan's great. There's no problem with lifespan, because everybody has a lifespan, including the ones who died at 3 months. And that seemed to show that polyunsaturated fats are, in men, harmful. They reduce your lifespan, and in women, doesn't matter. So there's something about these differences, and completely contrary to the advice we had for about 40 years to replace saturated fats with polyunsaturated fats. But that was never based on any trial evidence, that recommendation. And it was heavily influenced by industry, who said, don't you dare have say that meat is bad for people, that we now think that is. Move on.
Your arrows are disappearing.
Okay, right. So, but I would like to say that a Mendelian randomization, although it's claimed to be the same as a trial, it's not, because it's still open to selection bias. So you just don't do those studies. at the moment until we've worked out a solution, but some selection bias is unrecoverable, so then you can't do anything about it. I think MR is interesting because unlike a trial, it assesses the pathway, not the intervention. So it says you're actually looking at the intervention itself, at the pathway, so the puffer, whilst if you gave people pills, you'd be assessing in a trial, you'd be assessing whether the pills worked, not that it worked by that pathway. And because of the problem of selection bias, you always have to do it in a study of roughly the complete population. So it actually is telling you about public health interventions, not medical interventions. I mean, for the purists, the actual definition of the effect is very hazy. And I would always think it gives you more direction than this is the exact number. And it also allows you to use yet another design to avoid selection bias, which actually people didn't really believe was a design. So I keep publishing it to see if people will accidentally publish it without noticing. And then I can keep going on that. So here's an example where we used in a longevity design, you use age at recruitment as the outcome. Because if you've got a harmful genetic variant, then it will become rarer and rarer with age. So that's what we did here. And it was handy because the study we had only had people of average age 57. So we wanted to know about alcohol use before that. So we had the genetic instruments for alcohol use. We applied them both to age at recruitment and to lifespan. And we found, as you can see, that they make you younger at recruitment and they reduce your lifespan. So they're harmful throughout your life, alcohol use. And I think that's the view that people are coming to. There was an observational study that said that recently. But it's nice to be able to show it in that detail, and we could also show it for men and women separately. And obviously it seems to look worse for men, which is probably, I'm not sure why that would be, but there might be yet another explanation for that difference between men and women in overall life expectancy. So we did that. And just to explain when this comes up in genetic studies, because Mendelian randomization and genetic studies are used a lot. So I think, and maybe I'm wrong, that a genetic study needs to be representative of the birth cohorts who formed the population, not those who are currently alive. And otherwise, harmful variants, you'll get an attenuated or reversed effect. You don't want case control studies to use prevalent cases. This was something that was published in 1955 because it will make the exposures that reduce survival with disease look protective, because you're missing the people who didn't survive. The things that stop them surviving as cases will look protective. And you don't want to adjust for consequences of genetics in your genetic study, because then you may end up stratifying on a collider. So if you have a study of waist-tip ratio and you adjust for, so you're doing waist-tip ratio on genetics, you adjust for body mass index, then there's undoubtedly confounders that cause body mass index and waist-tip ratio. So you've now got an open pathway, not via genetics, from the genetics to the outcome. So you will get nonsense if you do that analysis. And then, so I've explained some of the ways you could try and get better estimates, some form of instrumental variable analysis. But you could try the other thing of the pharmacoepi, if you felt like it. And this is another very tricky area because it suffers from this thing called immortal time bias. And it's a weird thing because it's called immortal time bias and it's seen as some miscounting of time. But my student said it couldn't possibly be a miscounting of time because we don't even count time in a logistic regression and we get the right answer. So why would suddenly miscounting of time make a difference? So she ground away with the time varying DAGs for a long time, which generated the insight that the problem with pharmacoepi studies is that the exposure is aligning the start of the exposure and the start of the study. So if you have a study where the exposure starts after recruitment, then there'll be some people in your study who manage to die between when they're recruited and when they get the drug, say. And those people will be different because they went and died. So they will make the drug look great because the people who were never given it died. So you will just get a silly answer if you don't get these lined up. And this isn't actually something that only affects pharmacoepi. You get the same sort of thing if you asked people about the number of children they had, and you asked them some point in their life, because if a woman had one child and died, she can't possibly have any more. And so that person will have a short life. If the woman lived much longer, she could have 5 children. So it's when you get exactly the same problem, that you have to survive to have more children. So it's not the more children that make you live longer, it's the fact that you lived long enough to have more children. And the same thing if we have a cohort study where people change, people change their exposure status during the study, that's going to cause something horrible to happen. So that's one reason why the mortal time bias occurs, this thing. And the other is the exposure starts before recruitment. So if you start the exposure before recruitment, then the people can go and die before they're recruited. And that's selection bias again, if it's a harmful outcome. So pharmacoepidemiology is quite tricky again. And I think the key thing there is you have to use a new user design where you just use people who are new users and start the drug the moment you recruit them. And then you'll have got rid of these biases, and just whether you've still got confounding, that's another problem. So I think that's everything I have to say about why we need to look at chronic diseases, what are the difficulties in it, and what are some of the solutions. So I hope that's helpful. Thank you for your attention.
Thank you very much, Mary. And we have time now for questions. Up to 25 people in the meeting. It's good attendance.
Sometimes I will be able to tell me where I'm wrong.
Right, well, maybe I'll start us off with a question of for studying a disease that only has late onset, like Alzheimer's, how can you get around this selection bias? Because any exposure, unless it's not harmful for anything else except Alzheimer's, is going to cause this problem. So it has to be unique to Alzheimer's to even be able to study it.
Right, you need a different form. You need instrumental variable analysis, and you need the right instrument. So that's a great question, because there was a very interesting study of vaccine for chickenpox in Alzheimer's disease. And the way they did it was they used the introduction of the vaccine as an instrument. And the way it was done in Wales, in the UK, was people with their birthday up until a certain point could not have the vaccine. And people with a birth, maybe the 1st of April. So people born in March didn't have the vaccine. The people born in April did. Then, because the UK has a comprehensive health service, they just followed them up 10 years later and compared the two groups, because they're only born a month apart at most.
So that's an IV study of the effect of chickenpox
vaccine, on Alzheimer's.
The vaccine or of the
vaccine.
What about the effect of having chickenpox?
No, that was just because they gave them the vaccine. So the the ones whose birthdays were before the certain date didn't get it, and the ones with the birthday after did get the vaccine.
Yeah.
So if they compared those two groups, they'd know the effect of the chickenpox vaccine on the one for, I think it's the one for shingles. They're the same thing.
Yeah.
And you can.
My question is, could that also be an effect of having chickenpox, since it's presumably the group with the vaccine has less chickenpox than the group that did not have the vaccine?
Well, this is when they're 80 or something.
Okay.
So you do it when they did it, I think, when they were in their 70s. So it wouldn't be anything to do. And anyway, that giving them that vaccine, the only thing that it depended on was when their birthday was.
Right.
So it's completely random assignment, or close enough to. So if the assignment's random, you should get an interpretable, unconfounded estimate. And there was nothing there adding selection bias because it was offered to all of them.
Right. So I guess I'm just talking about shingles being part of a total effect. Like if you're trying to ask whether the the vaccine causes something, if it happens to be that having shingles causes it or protects from it, that would just be part of the total effect.
Yeah, I mean, all you found out from that is whether the vaccine works. Nothing else. But that would be really useful information. And the trial, weirdly enough, it showed it worked in women, but not men. And I have no idea about that bit. But in fact, the US are now offering it to everybody, I think. Older people from 65. In the UK, they're offering it from 75. Well, I mean, I think a bit more evidence would be good.
This was actually a study of the effectiveness of the vaccine in preventing shingles. Okay,
yeah,
okay.
yeah.
Got it.
Yeah, sorry, I didn't make that clear. So that's the sort of thing you can do, but you have to find the instrument out there all the time.
Oh, I see.
I have a
Hand
question.
raised. Dennis.
Hi, Mary. It's Dennis. Thanks for the presentation. I wanted to go back to your diagram where there was no further arrows after inflammation.
Yeah. Oh no, I just made that up. I could be wrong there.
Oh no, I'm not going to challenge it, but I just, because I know very little about these pathways, but I just wanted to highlight that with COVID infection and the problem of long COVID in some people after, there are many different pathophysiological pathways that people are hypothesizing are causing it, or probably more than one. And one of them is what they call an inflammation pathway. And another piece of information is that there have been some trials, some of the trials of antivirals seem to reduce the risk of long COVID, and that makes sense if the infection is causing the inflammation. But there are also, you may know this, a trial of metformin that also showed a substantially reduced risk. And I just put it out there because it seems like a piece of information you might be able to integrate here if you haven't seen it.
What did the trial of metformin find a reduction in?
Long COVID. Okay, yeah, I should make the connection.
Okay,
so, and it's viewed as a multi-organ, systemic kind of effect that is, for example, increasing blood pressure, increasing the risk of heart disease and other things. And I just found it interesting listening to some of your hypothesized pathways and seeing metformin up at the top there.
Yeah, and I hadn't really thought about it in terms of COVID. I'm really looking at more chronic diseases. I suppose that long COVID is a chronic disease, but I hadn't thought of that. Thank you. I'll think about it some more.
Thanks, Dennis. Any other questions? Yeah, ahead.
Chloe has her hand raised.
Chloe.
Yeah, hi, can you hear me? So I'm trying to figure out my mic
Yes.
situation. Oh, perfect.
Yes.
Hi, Mary. So my question that I've been struggling with, because I always want to do an instrumental variable analysis, but the nagging self-doubt I always have is that like nothing is really an instrument. Like I always feel like I can think of a way why this is not truly an instrument. And I was wondering if you had any thoughts on that.
Well, obviously, well, the study, I think things like the example I was giving, whether people got a vaccine simply because of the date of their birth within a very short time period, those people should be equivalent. You know, the ones who did and the ones who didn't. So, and then, you know, the date of the available, who was eligible and who wasn't, does seem to me to be like a sort of reasonable instrument. Would you think that one was, or what would you see as the issue there?
I mean, I think that one is good, but it's just I don't want to like ramble too much, but I remember I was reviewing my notes from Epi4. One thing we talked about was like distance from a hospital as an instrument, and I felt like, but you know, the reason people live, you know, more rurally or further away from places that can have important socioeconomic, I don't know, drivers of why they live further from hospitals. And so I always think about that, and then I don't know, with my own analysis, when I'm mostly working with cohort study data and not, you know, like population data, it's hard for me to think of when I can find instruments there.
I think you're right. It is very difficult to find instruments, and I think people feel that that example about distance to hospital is not a particularly good one.
Okay.
So it's just one of the few that was around. I mean, I think the thing that's changed the interest to some extent is using genetic instruments. And although it's sort of unpopular now, it does give reasonable results. I think from your perspective, you would probably prefer genetic instruments that are biologically known to affect the exposure, wouldn't you?
Yeah.
Yeah, and in nowadays, I mean, in the past, people just selected the instruments on statistical grounds, but now I think people are moving much more to selecting them on physiological grounds. And I think that does give better estimates. In that alcohol study that we did, we realized we got more reliable, or what looked like more sensible estimates when we just used one SNP that's physiologically related to alcohol rather than 200, which predicted it, but are not necessarily alcohol use, but are not necessarily physiologically related. So you might find that a slightly more reasonable way of doing Mendelian randomization. And otherwise, I mean, the economists use it a lot, and they're always looking at differences in law or something like that. You know, that's how they found the effects of trans fat, by comparing one state in the new US and another state neighboring, where one banned trans fat and the other didn't. I mean, obviously, you could say there might still be differences between the states, but if you sort of got the people on the border between the two states, they might be reasonably equivalent. So there are, and I think it's a question all the time of looking for what could be valid instruments. Does that help at all?
I mean, I think it does. It helps a bit. It reinforces the feelings I have about it, I think. Yeah.
But the alternatives, are they any better?
Right. So it's one of those things where it's just like there isn't a better solution. So even if this is not a perfect solution, it's better than doing nothing.
Well, I mean, I totally agree with you in that I don't like doing studies where I don't think what I'm doing is valid. So that's why I didn't mention it, but I don't normally do observational studies because of those 3 papers I showed about how they were all open to these biases. And I would think about which Mendelian randomization studies to do. I would not do a Mendelian randomization study of anything on stroke because I think it's open to selection bias. And I wouldn't do one of Alzheimer's disease because I think it's open to selection bias. So even with the method you think is reasonable, you still have to think whether you're going to get a valid answer and convince yourself of that before you start.
Seems to me the other thing you can think about is if you have multiple different studies pointing to the same thing when you can't plausibly say that they're all causing the same selection bias problem. That maybe any one of them could be, but to say that they all are starts to sound denialist.
Yeah, people talk a lot about triangulation. If they get consistency across different methods, they're a lot happier. And they need to worry about both confounding and selection bias. And then you can use things like control outcomes and control exposures, but sometimes it's a bit hard to know if they really were a control, but you can try those things as well to convince yourself. I think it might a bit goes back to what CEPH said. If we had a better idea about the biological mechanisms, it might be easier for us to decide what we should be doing as well. I don't know what other people think on that.
I mean, it makes sense to me. You can imagine in the case of the genetic instrument, one that where you know at least one of the effects of that SNP. It's more plausible than something just detected that you have no idea what it does, and it's perfectly plausible that it's just correlated with something else, and that's to do with ancestry or whatnot that you haven't managed to remove.
Yeah, I mean, but also we have to remember there's no point in doing absolutely nothing. You might as well do the best thing that you think you can do at the moment. And in doing so, you may find out further flaws. Because one of the reasons why I've seen all these flaws is because I do lots and lots of stuff. So then you see these anomalies and you start thinking. So even getting the wrong answer is helpful sometimes because you think, where did that come from? What's happened? And you learn something. So there's no point in just saying, I won't do any of it. You've got to keep going, but try all the time to find the things that look most valid to you.
Brianna.
Hi, thank you so much. One of the things that I've been wondering about is the validity of the exposure, actually. In the counterfactual framework, we talk about consistency and having well-defined interventions. And there's a paper about, how obesity is not a well-defined intervention and it can be created by lots, you could lose weight through lots of different ways. And I'm just wondering if that concept applies to instrumental variable analyses like Mendelian randomization.
Yes, definitely, because I think that what we're often thinking about, particularly now, is the instrument that works along one specific pathway, which we think is relevant. And then we could, for the same exposure, we might have a different instrument that worked on a different pathway, and we might try and identify those using some sort of factor analysis or have some sort of idea in our heads first. So yeah, you can definitely decide you're only going to use instruments, say, from a specific gene region, which you think is physiologically related to your exposure. And in fact, people do more and more of that now. So yeah.
So it's that we're using the gene and specifying the gene in order to specify the exposure for an intervention on it. We're not specifying the exposure itself.
So, well, say if I wanted to get genetic instruments for AMPK, which actually is very tricky, I would only look in the AMPK gene. Because then and if I wanted genetic instruments for statins, I'd only look in the HMGCR gene, because I know that's how it operates.
I see. So can I ask, if I'm looking at an exposure like a lipid, that's not really an intervention. It's a biomarker that goes across many different things. Would that be too non-well-defined in order to analyze it?
Well, currently, some things work well. Genetic instruments for lipids do seem to give answers that are really quite similar to what the trials give you. So it seems that some concepts are quite specific and some concepts are rather broad. There's an awful lot in just lipids. So it seems to work okay with just genetically selected instruments selected just on statistical grounds.
Okay.
But I think you could work it out by starting off with some control outcomes and see whether your instruments seem to make sense before you did anything more with them.
I see. Great.
There's no complete answerable rule book here. But there are lots of more tests you can do to try and see if you've got the right genetic instrument.
I have to say that the thing that struck me the most about Mary's talk was just the thoughtful consideration in each of these cases of the possibility that the hypothesis could be right or it could be wrong, and sort of an open-mindedness to both possibilities, and just seeking, being open to the possibility that there could be a cause here or there could not be a cause. And somehow that seems to me like an important step, just to not start off with the assumption, well, this is a such and such type of study, so there's no way that we can be sure of anything from it. Thinking of the saying that all studies are flawed. There are no perfect analyses, but ideally you can learn something or move the needle a little bit in one direction or another from a study.
Or decide not to do it again. But I think actually a really important bit of studies that I heard Richard Dole say 20 years ago now was you not only looked at the association you've got, the one you were looking for, so that he was talking about this in the context of one of his early studies on smoking and lung cancer. So he said, okay, so we did the case control study. We saw a much higher rate of lung cancer in the smokers. And then we said to ourselves, does it make sense? Do countries with higher smoking rates have more lung cancer? Do people who smoke more than others have more lung cancer? Do men have more lung cancer than women? Because in the 50s, men smoked more than women. So I think you can always do this. Does it make sense, just in terms of everything else I know as well, to try and reassure yourself? So sort of a sanity check all the time.
Yeah, well put. Any final questions? Well, I've really enjoyed this discussion, and I'm very thankful to you, Mary, for coming in and agreeing to present today. I can see by the number of attendees, lots of people are interested in what you're doing. I just want to mention to everyone else that we still have spots for these forums through the rest of the year. So any students or faculty who have work that they would like to present, please let me know, and I will schedule you into one of our upcoming forums.